much, sir. And so I'll be sharing some videos demonstrating how we can safely conquer this brown, black, and white beauties, what I call them. Being in India, we need to tackle with these kind of cataract day in, day out. So this is the technique for black cataract, which I presented in 2010 in ASCRS Paris, what I call drill and chop technique. And for years I've been teaching this, and it works wonderfully in almost all kind of harder cataract. So we all know that these cataracts, they need some special considerations, that we need to stain anterior capsule so that we make a capsular axis of good size, and the axis should not be very small, because when we are chopping, we may damage the anti-capsular axis margin, and if it's too large, we lose all the benefits of putting the IOL in the capsular bag. So it has to be adequate size capsular axis, and once you make capsular axis of adequate size, this is 1.8 millimeter phaco tip, which I routinely use. And so the idea here is, we all know that the main strength of this kind of cataract lies in the central endonucleus. The central endonuclear core is very dense and hard in these cataract, so we need to tackle that first. So what I'm doing here is drilling in the center. So you are drilling in the center and rotating the nucleus by chopper and drilling deep down the surface. So you are weakening the central core. So by weakening this central core, you are creating a good depth also. And how does it help is, when you chop the nucleus, your phaco tip is holding the nucleus at a deeper level, and when you are chopping, your chop becomes much more effective, believe me. So it's different from crater and chop technique. Is, and in crater and chop, what has been described by Dr. Vajpayee is, you make a crater till almost capsular axis margin. But here, I'm just made drill here in the center. So you have this entire area good for chopping, and you have this area for holding the nucleus. So once you have drilled adequately deeper, so you can hold the nucleus. It's not a trench, so you can hold it from anywhere you want. You feel when you realize that it's you're drilled deep enough. So once you have this hold, you see, you chop like this, and it separates and divide it antero-posteriorly all the way throughout. So rotate the nucleus 180 degree, and once you rotate it, again hold from one side. I turn my bevel on right side, hold it, and chop it again, and this completes the crack. And this is our aim, to have two complete half. And see, what drilling has helped is, it has made a bowl there. So there are no thick leathery fibers there. Again, you rotate 90 degree, and again divide the nucleus. And once you have this, you can further subdivide the nucleus into smaller pieces, and take all these pieces one by one. Remember that you need to supplement with a viscoelastic, which is chondroitin sulfate based, which protects the corneal endothelium, because of course these cases you need to deliver more energy as compared to the softer cataracts. So you need to protect your endothelium. Keep on putting the OVD in between, so that your endothelium is safeguarded from all the energy which is being delivered. And then you finish the case and put the IOL in capsular bag. So that was coming to the white cataracts. We all know these kind of white cataracts which are intumescent. The problem in these kind of cataract is of capsular axis, because it's all liquefied cortical matter which is pent up inside and ready to come out. So I put a cohesive viscoelastic there, and what I use is a sequential two-stage capsular axis. This is a 26 gauge bend needle. Go ahead in the center. So this central area is the safest area where you can create a small capsular axis, and then debulk the capsular bag, and then enlarge the axis to the size you need. So I go ahead and see the rexis you are trying to fashion here is curvilinear. As soon as I make a cut, my direction is like this, curvilinear. So once you have this, again go ahead and put OVD in front of it, and with the micro forceps, you make a very small rexis there in the center. And once you have this, go with a 27 gauge cannula and see the amount of fluid which is coming. See the entire fluid which is coming. It's important that you don't only go from main port, you go from side port, because it's the entire 360 degree which you intend to debulk, because this liquefied cortical matter is there all around. So once you have done debulking, you go ahead with micro scissors, give a small cut, and you use micro capsulorhexis forceps. And you can see I can create a capsulorhexis of adequate size without any problem. So believe me, the time which you spend in making a very small rhexis in the center, debulking it, it helps you in almost all the cases of intumescent cataract. Nothing great in chopping them, because most of the cases are brittle, but still there is no epinucleus, you need to be careful. And this is the hydroimplantation technique which I described in 2010, and it was published in JCRS. So just put irrigation cannula there and you implant IOL. And this is the modified hydrostitch cannula which goes by my name. It is very helpful in topical cases. This is another case of phacoemulsified glaucoma. You can see this patient had attack of phacoemulsified glaucoma, again done under topical anesthesia. Again, same principle, go ahead, make very small rhexis in center, and after this, see the amount of fluid which is coming. You try to make a rhexis in one go in these kind of cases, it will definitely, most of cases going to go in periphery. But debulk like this, you are safer. See the amount of fluid which is coming. So I go ahead from side port also. So go from both the side ports, main ports, try to debulk as much as possible before trying to enlarge the rhexis. So again, I'm enlarging the rhexis very easily. But you need to use microcapsulorhexis forceps, because by that you can control the direction very well as compared to cystitome. In cystitome, you'll never get this type of control. So you should always have these 23 gauge micro forceps which goes through side port. You may need to use left hand, right hand, but so this finishes the case easily. Another case of Morgagnian cataract. Now, problem in Morgagnian cataract is not of increased intracapsular pressure. The problem here is that zonules are weak, anterior capsules is fibrotic. So the moment you give a nick here, the fluid comes out and pressure drops down. So rhexis never extend in these, but you need to be careful while you are fashioning the capsulorhexis that you don't damage the zonules. The fluid keeps on coming. You need to keep on either irrigating it out, or you need to push OVD to see the view. So you need to be careful through fibrotic areas. And once you have this, the nucleus here is very mobile. So the trick here is to do chopping from horizontal chopping, get your chopper from equator, hold it. They see the leathery fibers there. So in these kind of mobile cataract, first you don't get a good hold. So you need to drill in center and hold it nicely and do horizontal chopping in these kind of cases. See, again, I'm holding it, lifting it above towards endothelium and dividing it into smaller pieces. So once you have, you can easily emulsify the. And you should always secondarily enlarge the rhexis after putting IOL so that you have adequate size of the capsulorhexis in the end. I think my time is also up. So with this, I'll finish my presentation. Thank you very much.